telemedicine visits to all uninsured Coloradans who are sick at home and scared and don't have a doctor to call. The other thing I've been doing for the past 3 years is I'm the Chief Medical Officer for a healthcare startup based out of St. Louis called SteadyMD. And there we've really changed the primary care model of having an online doctor who is aligned with their patients and is always connected and available to them via technology. So with SteadyMD, like everyone goes through a matching quiz, and for me, like I'm a big runner, I like to climb and bike. So my patients come in from all over the country with similar interests, and I find that having that kind of rapport can really help with keeping my patients healthy over the long term. And like with SteadyMD, it's very different than most telemedicine options in that most telemedicine is really geared at episodic care or urgent care. And with both my clinic practice in Westminster and SteadyMD, really the idea is a long-standing relationship with a doctor who knows you to keep you healthy over the long term. And like really my biggest kind of interest is just kind of working on ways to improve and reinvent this like doctor-patient relationship and delivery of care. And that's why I'm really excited to be on with all you guys today.
Good. Thank you. Dr. Goss, yeah. I'll turn it to you.
Great, thank you. So I'm Foster Goss. I'm an associate professor of emergency medicine at the University of Colorado and work as an emergency physician down at UC Health. And I've been practicing emergency medicine for the last 12 years and also did fellowship in biomedical informatics at Harvard and have been very interested in how we use technology to drive improvements in patient safety and quality. And I took the path of a clinician and really as a researcher, got very interested in applying for different NIH grants, and that was my life really for the last 5 to 7 years. And but I also realized that a lot of these ideas that came from my clinical practice could also be used in the market, and that there was an importance in terms of beyond just the life cycle of the grant to actually bringing these solutions to a wider audience. And that's why I started CareLoop, which was really focused, again, all of my grants have come out of clinical experiences that I've had that have translated into a technology solution, and CareLoop was the same. I saw a lot of patients that were falling through the cracks and realizing that the single most important thing that we can do to help these patients is actually change the way that we communicate with them and to change the way that we engage them in the healthcare system. And we follow up with them, we check in with them. Right now, we live in this sort of transactional economy where we go in, we seek care. And to what Dr. Emder was talking about, we really need to be focusing on prevention and instead of moving beyond just the episodic transactional care. So CareLoop was really designed to do that. And I'm the chief medical officer, founder and president of that company. And then I also wear a hat as an informaticist, a clinical informaticist at UC Health, where I've been very involved in a lot of the innovation efforts at UC Health, working with different companies that the health center has partnered with, and really thinking about how we leverage that living lab that we have to help drive innovation and advances in healthcare.
Thank you. Liz, do you want to go ahead? I think you're on mute. I'm gonna try to unmute. Oh, yeah. Good.
I'm Liz Ka. I have a background in medicine. I've focused my career on healthcare strategy and innovation, and I'm really motivated by having a big impact in healthcare. So how can we really move the needle? How can we really transform lives? And so that brought me to SomaLogic a couple of years ago. So SomaLogic is a Boulder-based startup, yay Boulder. And we've been around for a while and we measure proteins, so AKA proteomics. So you've probably heard of genomics before, and genomics is the study of your genes, which can provide some useful health information, but your genes are static throughout your life. and genes code for proteins. And proteins are really the molecules that get stuff done in the body. They carry out our bodily functions, they mediate the effects of drugs, and they change depending on our lifestyle, our diet, whether or not we get exercise, our environment, etc. So proteins can actually tell you a lot more information about your health than genes can. And they're also very hard to measure, but our founder and the brilliant scientists at SomaLogic have figured out to do that really quickly, accurately, and affordably. So we have a platform that measures 5,000 proteins in the blood, and these data points can be used by researchers directly. And then we've also done our own research to create tests by applying machine learning to proteomic data and clinical outcomes to reveal valuable insights. So we have 3 channels. The first is really a research channel where researchers in pharma and academia use the platform to gain a deeper understanding of the biology behind disease, to identify potential drug targets, etc. The second channel is a self-pay channel where we offer a bundle of medical tests, and we launched this last year. The tests are offered in about a dozen front-range medical practices, and patients pay out of pocket for 10 tests that are based on the 5,000 protein measurements. And the tests are things like, what is my risk of having a cardiovascular event? And it's based on the proteins in my blood, my genetics, but also what I've been up to during the course of my life, whether I've been healthy or not. And then the other tests are things like liver fat, body fat, VO2 max, all really interesting things to be able to get from a blood test. And then our third channel is the traditional medical channel. So this is really our newest channel where we partner with health systems to deliver proteomic test results so we can measure the impact. And my role specifically has been to focus on the strategic approach, first to this self-pay channel leading up to our launch last year, and then more recently focusing on health system strategy and partnerships.
Good, thanks. We're so thrilled they're here today. And Nabil, I'll turn it to you for a last introduction before we get started.
Yeah, hi everyone. My name is Nabil Megji. And I am actually based in Denver, so a little different than all the panelists that we have. I'm the Chief Product Officer at Dispatch Health. So for those of you who know Dispatch Health, we provide healthcare in the home, primarily urgent care / emergency room level care to the home. And we are partnered with pretty much every insurance company there is. So it's no different, no more additional cost for a patient than going to the urgent care. We're in 19 markets all across the US. We just launched our 19th market a couple of weeks ago during COVID. So that was pretty interesting. We'll talk about it later. And we'll see around 170,000 patients this year. So a lot of great things happening just in Rhino here in Denver.
Thank you. Thanks, Nabil, for joining us all the way from Denver, virtually. We're thrilled to have you all here today. And so a lot of you have focused the last really 8 weeks on pivoting your model, your care models. Maybe you're seeing more patients online than you had before. We've seen upticks in business regarding different testing. Dr. Goss, I'd love to hear a little bit first from you about UC Health's response, and then specifically how any pivots CareLoop has been making.
Sure. So we definitely had to reinvent the way we deliver care. We fortunately had started a virtual health center a couple of years ago. So we had some of the infrastructure actually in place. However, there was not really much volume that we had. We maybe would see 20 patients a day. And when COVID started, that quickly changed. And it was quite fascinating to watch our emergency department visits plummet. And we were down about 40% because nobody wanted to go to the emergency department. And they were being encouraged to stay home and isolate. However, our virtual care visits shot up about 5,000%. So we went from seeing 20, to thousands of patients. And that was a pretty significant change in how we were delivering our care. Of course, all the elective surgeries had been canceled. And then there was a lot of, so that was more on the ambulatory side. Then there was a lot of changes that happened in the emergency department, also on the floors on the hospital. And we were watching closely what was going on in New York. and really trying to plan for that surge, which we definitely had a spike, but it has been relatively steady. I think we've had absolutely remarkable leadership that has allowed us to move sort of rather smoothly through this. We've never had shortages of PPE. We've had ventilators. We've obviously had to flex a lot of our ICU teams to help address the increase in volume. And then this was very dynamic. I mean, every single day, I think we were hearing sort of new processes that we were using to actually take care of patients. The science was being created as we knew it. And we were having to think about how we could actually communicate with patients remotely, really telehealth, but actually inpatient telehealth. So that was a big shift. In the emergency department, actually, we used a lot of times just a phone to be able to call the patient's room and communicate with them and stand outside the door and talk with them. And we definitely have learned a lot, I think, in terms of preparation and planning. We also have learned a lot about developing the importance of communication and developing tools that leverage technology to actually help us follow the same care path, for example, for a patient with COVID. And so we leveraged a company actually that we had partnered with several years ago called AgileMD to put all of our clinical pathways up onto basically that could be shared. And we could actually look and see how we were supposed to risk stratify patients and what orders we were supposed to put in for patients, who we're supposed to test, who we're not supposed to test. So that was actually instrumental and it was obviously evolving as we learned more about COVID. And then we had to develop sort of new ways of communicating with patients. And I think that's really, where CareLoop, now putting my CareLoop hat on, I think that was really our focus. CareLoop has been working in nursing homes and then also acute care centers. So we were working in emergency departments as well as nursing homes. And that's right now, I mean, we've all sort of seen sort of what's been going on in nursing homes and the struggle with communication. And even for patients that are, say, in a hospital, they're very tight visitor restrictions. And they're often not allowed to be in the nursing home or in the hospital. And so with CareLoop, we really were focusing on how we could improve that communication with the patient. And then also improve communication with the care team as well. Dispatch is one of our partners, and we work to actually turn on video conferencing for them so that they could basically communicate very effectively between the care team around the patient and help drive better care for their patients. So it's been definitely an eye-opening experience. It's really exciting because I think that this is the nudge or the push that healthcare really needed to really help us move in the direction that we as innovators always saw us going, but to actually get sort of large healthcare systems to go in that direction. I think this really forced us into using technology and leveraging it in the pandemic.
So a quick follow-up question there. You mentioned the 40% drop in ED visits. Do you think that was because many of the people coming to the ED prior didn't really need to be there, or were those visits diverting to telehealth, to that telehealth surge you mentioned, or just fewer people getting injured because we're staying at home?
Yeah, so that's a great question. I think that it's probably a combination of all of those. So I think that there's definitely concern about coming into the emergency department. Part of the messaging that we're trying to convey now to patients is that it is safe to come to the emergency department. It is safe to come into a healthcare system. We have seen, unfortunately, patients who have put off their symptoms and their abdominal pain. So every abdominal pain that's an appendicitis is perforated. Patients who are having numbness or tingling and they're putting it off, and they come in, they've had a stroke. And unfortunately, there's limited, after, say it's been several days, there's limited sort of treatments that we can do for that. And I think also a lot of visits have been shifted to virtual care. So we have been pushing that to say, you know, if you do feel like you need to see somebody or you have a question, you know, first go to virtual care. But definitely, it's really important for the public to know that it is safe to go to an emergency department. If you are concerned, you do need to go. Certainly some of those visits that we get to the emergency department, particularly for trauma, alcohol-related or drug-related events, you know, those have decreased because people are not driving as much, and there's not as much perhaps intoxication that we're seeing, or people coming in, you know, after traumatic events that might be happening, say from you know, sporting events or things of that nature.
Yeah, I can.
Tell me, yeah, good.
I was gonna jump in. Yeah, so I think from our end, you know, we have seen quite an uptick in terms of requests of patients who want to be seen in the home. So absolutely, I mean, I think if the care requires an emergency room level visit, then that care should be there, right? No doubt, right? All the examples that Dr. Goss pointed out, those need to go to the emergency room, and it's safe to go there. But for things that you know, probably shouldn't be in the emergency room, we have seen quite a bit of interest. One, because patients are in the home and they want to be seen there, so we've seen that. And second, we have realized that, you know, there's also been a push from our partners in the market to say, hey, you know, this shouldn't be in the hospital. This shouldn't be the emergency room. Hey, dispatch, can you go and see this patient? So it has been a really interesting dynamic working with everyone in the ecosystem to really right-size care and say, hey, this care should be in the hospital. This care should be in the emergency room. But you know what? This care shouldn't be in there, and therefore, companies like ours, Dispatch Health, but also telemedicine and other new modalities that have got a lot of adoption have really been brought up, which I think it's really encouraging for us. One, from the patient experience standpoint, right? But second, from the cost of care for us in the US as well. So I think it's really encouraging. I think there's a lot of innovations like that have happened that I think it's here to stay.
And Liz, you know, you represent a different side of care, right? And specifically at SomaLogic. Can you tell us a little bit about any pivots or changes you've made as a result of the pandemic?
Yeah, for us, we have definitely pivoted significantly. You know, as I mentioned, we have 3 channels, 2 of which focus on care delivery, but it's generally non-urgent care delivery. And our 3rd channel is a research product, which can help us understand more about this disease. So we've really focused on providing our platform as widely as possible to researchers as quickly as possible for COVID samples. And so there's a lot of questions about COVID. So, you know, of people that are exposed, why do some people not get sick and other people do get sick? Of people that develop disease, why are some people very mild or even asymptomatic, but other people develop very severe disease? And these are questions that researchers are trying to answer with our platform. They're also working on a lot of aspects related to drug and vaccine development. So our pivot first has been to shift all of our resources that can contribute towards a COVID response to that COVID response. So making sure that all internal resources are available to focus on that. We've also eliminated our typical terms and conditions. So we've tried to make contracting as easy as possible to get these samples in the door as quickly as possible. Once they're in the door, the COVID samples have immediate priority in our labs. Everyone that can work remotely is working remotely, but our labs require personnel to be in-person processing. And again, we're focusing first on our COVID samples. And then we're also prioritizing the anonymization and sharing of the data wherever possible as quickly as possible, so that that data can be available for external researchers to analyze, for other researchers to combine with additional data sets. and to be able to try to understand the disease as quickly as possible. And then the last piece is we're pursuing internal COVID research too. So we reallocated some of our other research projects, and we're trying to better understand the viral proteins, identify finding aptamers to those proteins, potentially create rapid diagnostic tests, things along those lines. So, we've really tried to mobilize and, have as big an impact as possible with the resources and the capabilities that we have.
That's great. And Dr. Emder, with StudyMD, have you noticed or have many changes to your platform or the amount of people that are trying to get
just
such
a great question for me. So number one, like at our clinic in Westminster, we went from, a standard kind of brick and mortar clinic model to 100% virtual, like overnight, back in March. And for those who are not familiar with telemedicine, like it's really been around, I think, since the 1920s, like when telephone was like invented, people like started calling their doctor. And just historically, the utilization rates have been really low for a number of reasons. Number one has really been around reimbursement. In the way like our fee-for-system billing is set up with insurance companies, I mean, doctors are reimbursed when patients come in for a visit. So that's been one of the biggest barriers to telemedicine. And with COVID, 3 years ago when I left my job at the hospital, when I shared with my colleagues that I was leaving my respected hospital position to be an internet doctor, like the reactions I got were just crazy. And then just like a couple months ago, I saw in the New England Journal of Medicine, which is like the main publication for doctors and for research, there was like an editorial that said, virtually perfect telemedicine for COVID-19. I was like, wow, like it's amazing how like things have like really changed just overnight, where people are like, you're an internet doctor, and then all of a sudden, or like you're like at the fringe one day as like this internet doctor, and the next, like people actually realize the value in being able to care for people using different modalities. So at our clinic, we went from seeing patients in person to doing both telephone and video visits. And at first the adoption still wasn't great. Like historically, even with like big national players out there like Teladoc, American Well, I bet most people who are on this call right now probably have a benefit for urgent care telemedicine, but the utilization rates have always been about like 1 to 3%. They've been very low, like people haven't used them. But like to Nabil's point, in this modern day, especially in an era of like a projected physician shortage, primary care physician shortage in the country of like 50,000 providers over the next couple of years, we need to figure out ways to make sure that people are seen in the right venue. So there are definitely times when someone needs to be seen in person in an emergency room. There's times when people might need to come into an office for like a cervical cancer screening or other things that require like that in-person exam. And then there's lots of things that might not even need an exam, where it can be done just through like questionnaire with like a quick review review of your chart by a doctor, a PA, or an NP to make sure that like prescribing medication for a urinary tract infection or for some other kind of low risk process, like that might be something that you can do from like the convenience of a couple text messages. So just like figuring out that balance is really where we have to move forward as a society to make sure that we can provide high value care to really all citizens, because healthcare it's really something that like any developed society, like everyone needs to have access. And preventative care, like an ounce of prevention is like more than a pound of cure. Like it's just so true. I mean, if you're keeping people healthy and out of the hospital, like that's how we can save healthcare dollars as a society.
Totally agree. Go ahead, Nico.
quick follow-up. You know, a lot of all of your responses were focused on the market, right? How are we changing our organizations based on what's going on in the market? There's a lot of uncertainty in the market right now, and as all of us running small businesses or growing, scaling businesses, I'd love to hear about what you're doing internally to, based on that uncertainty in the market. How are you changing the way you're operating? How are you planning for that market uncertainty?
Yeah, I think I can start off there. I think, you know, that's been a key focus of ours. And, you know, one, you know, with COVID, there's a lot of unanswered questions from a clinical standpoint, right? From our frontline providers, but also as human beings, right? There's a lot of things that are changing, right? Kids are at home now. There's new ways to do everything, right? Grocery shopping and, you know, going to the park, and there's all these questions, you know, burden us in our minds as we think about our employees. So I think what we did at Dispatch was spend a ton of time communicating to our internal employees. We have had a town hall meeting every week where we bring the whole company in and just level set on where things are, what we know, what we don't know, and answer a question and have a forum for our employees to ask their questions and for us to address. Some of it is just listening, right? And just getting input. Some of it is being able to address and answer, but being completely transparent on where things are. So I'll give you an example. We go across 19 markets. We're also in New Jersey, which is, you know, very close to New York and the epicenter of everything that was happening. We were still having our teams going to patients' home, but there was questions around, you know, provider safety. How should I think about this? At that point, it was really one of our challenges that we have faced is accessing PPE. It was like super hard. We can talk about that all day long. I think every part of the world we tried to source PPE from, but it was hard to get. And second, getting tests was super hard as well, right? But being able to just level set with our employees and just tell them where we're at. The good thing is things have progressed, and now we have PPE in place, we have testing in place, and we're doing testing all across the US. But I think for us internally, we had to double click and double down on just internal communication, one, and two, just provide complete transparency that, listen, we are growing, right? Things are moving in the right direction. There's no like layoffs. Everybody is secure with their jobs. At least comfort them there so that they don't need to worry about that aspect of their life. So those are a few points from Dispatch.
Mm-hmm.
So from my perspective, both at my clinic and with SteadyMD, both of those practices do not bill health insurance companies, and they're both pretty small, nimble organizations. So we're kind of planning for an increase in seeing people who don't have insurance. We're also like constantly evaluating kind of other ways to help with the COVID response and keeping employees safe, how to get people back to work. So I do think with COVID, there's going to be lots of other opportunities for healthcare organizations to help out to kind of reopen things up.
Yeah. We've all talked a lot about fundamental changes that are happening to your businesses and the way things are operating. This will be my last question before we open it up to the audience. We already have 3 really great questions in. If you see the Q&A box at the bottom of your screen, we've talked about changes. I'd love each of you to answer, what's going to be the one thing that sticks around and you can't say telemedicine? Who's going to go first?
Yeah, no, I can go first.
Oh yeah, go Dr. Ember. Thank you.
I think just as a generation, this is the first time that we've really seen pandemic and like a disease that really affects a whole society. And this is not a unique time to the history of our species. But I do think it's going to raise a completely new awareness of like the importance of vaccinations and how they can really help save lives and keep societies running. But also a new respect for healthcare. Like it's just been amazing to see like all the support to like our nurses, our respiratory therapists, everyone who works in the hospital. Also with doctors, because like, you know, over the past, like my career, I can't always say I've felt like that much respect of like going in and like kind of being there on the front lines and taking care of people and risking yourself to diseases, which is something that's always, that's something that any healthcare provider opens themselves up to every day, with like needle stick injuries and other things. So that's not going away. And the other thing that I hope doesn't go away is the importance of having good baseline health. Because what we've learned with COVID is the people who are most at risk are those who have underlying chronic diseases, namely like diabetes, heart disease, hypertension, underlying lung disease. So all of a sudden there's a much more tangible reason to try to be healthy.
I think for me, the one thing that I think is going to change and I hope continues to stick around is the speed of innovation. So when we're able to remove obstacles from innovators, from providers, from frontline workers, from the people that are really trying to change things in a positive way, then we see innovation happen much more quickly. And I think the urgency of this situation has allowed that to happen. And I believe and hope that we'll continue to see that moving forward.
Yeah, I think both those comments are great, and I think I echo both. I think on the other comment would be around really around the patient and the patient's way of interacting with healthcare, right? So we have always interacted in a very facility-based model, right? So we have to go into a facility, and I think that's why the adoptions of other modalities have just taken a back seat, just because, you know, it takes a lot to change human behavior and human perception as well. So I think this has really expedited and accelerated a lot of those behavioral change. So I think now that you know, hundred thousands of patients have experienced healthcare in a different modality, telemedicine, if you will, you know, chat-based, whatever. Now, I think given that they're able to see that, hey, it's high level, high quality care, right? But I could do it in my comfort of my schedule, right? I don't have to block half a day, think about transportation, think about going to the doctor's office, waiting for you know 15, 20 minutes in a waiting room, right? And then going to see my provider and then figuring out all the other logistics. I think now that we know that for certain conditions and for certain illnesses, you can be in the comfort of your home, right? And you can then interact with healthcare in your terms. I think that's there to stay. I think this really gave a push to consumerism in healthcare that I think we've been talking about for such a long time, and I think this has accelerated that. So I'm hoping that that's here to stay.
Yeah, I would also echo what everyone else has said, and Nabil. It's been amazing to see teams of healthcare providers come together from multiple specialties. So for example, our COVID ICU teams are comprised of pulmonologists, hospitalists, critical surgical teams. Really, this is a multidisciplinary team that has come together to serve patients suffering with COVID. And I think that has never really happened before. And I think that's truly remarkable in terms of how we realize that we are not just siloed in our specialty, and that we can actually come together to serve and care for critically ill patients together and be really effective at that. Mm-hmm. I think that the speed of innovation, the speed of change that's happened is remarkable to get these very, large sort of monolithic systems to adapt and change to the pressures that were put on us is remarkable. And I'm absolutely amazed at the agility that we've seen and the creativity of these large academic or community medical centers, or even critical access hospitals. They've had to reinvent how they deliver care. And I think that just speaks to the creativity and the innovation of people and the way that we're able to work together to come around and solve for a problem that we're facing, no matter what specialty we're from. The other thing that I think is going to fundamentally change is the way that definitely, we've found more efficient ways to deliver care actually through this. And whether it be asking questions before a visit, whether it be the remote patient monitoring, so thinking about the patient after they leave and they go home, and how do we provide care in the home? How do we check in on patients and make sure that they're on the right path and they're getting better? We had a very interesting disease where the science of this is being created as we speak. But this is a disease that we knew that patients got sick later on in their course, and they were asymptomatic for a period of time. It felt like just a normal cold, but then it got really severe at around days 7 through 10. And thinking about how perhaps we extend care beyond the walls of the hospital, how we extend, how we use medical devices, and we're able to check in with patients and provide care in the home. And I think that is something that will stay. And I think COVID was the perfect use case, if you would say, for us to throw this remote monitoring tools against the wall and see if they stick. But now we know that they work, and how, thinking about this to other disease states, maybe, or chronic illnesses,
Right.
how this can be leveraged,
Right.
and how we can actually deliver this type of care remotely.
Yeah, good.
Is really, I think, going to be something that changes and sticks.
I agree. Nico, what's going to stick around in your mind? And then we're going to jump to the questions. We have so many good ones.
Oh, I think Nabil really took my answer, just the shift towards consumerism in healthcare. It's something we've talked about for a long time, but this is a catalyst that it gave, especially young invincibles like myself, it gave us a reason to be engaged in our care more than normal. And because of that engagement, I think we're much more prone to expect more of a better digital experience from our healthcare moving forward.
Yeah, good. I want all those things that everyone talked about, from centralization of the patient to, thinking of different care models. And one of the questions that came in was, we've all been talking about moving with this unprecedented speed. Liz, you mentioned you've changed your contracting terms at SomaLogic. As things normalize and we're out of pandemic mode, what can we do as an industry to keep the momentum in our speed, but without cutting corners?
I think that's a great question. I think that part of the solution is that a precedent has been set. So once you're able to do things really quickly, you can always reference that and say, hey, remember when we did this quickly? Can we do it quickly again? And I think, in the question, there is that inherent balance of without cutting corners. And so, I know the other people on this call are certainly not suggesting that we need to compromise the safety of patients. And so I want to make that totally clear. But I think a lot of times when these partnerships between large institutions, whether they be, biopharmaceutical companies or academic medical centers or whatnot, there's a lot of protection. There's a lot of desire to protect my IP, my data, instead of collaborating and sharing and doing what's best for patients as a whole. And I think that it will require a really strategic approach, and we're going to have to constantly remind all of the players involved that, hey, this isn't just about what's best for any one individual company. Of course, we want all of the companies to be able to succeed, but this is really about what's best for all of us, as we could all end up patients one day.
Good. Another question is, I think it says, I think it was Josh who mentioned this, but the shortage of primary care physicians. physicians is a reality. If this isn't going away, how do you think the healthcare system will continue to evolve to meet demand, aside from the NP/PA type care providers who can be just as holistic with providing care as those that are MDs and DOs?
Yeah, so one thing that I always like to cite is that healthcare is one of the few industries that has not really gained any efficiencies with the use of technology. So, back when I started my career, before the electronic medical record, it was arguably faster for me to see a patient and document my care than it is now, 20 years later. The electronic medical records have really come about as a way to capture charges and haven't really made the lives of practitioners easier. I think that one of the ways to improve, kind of like help with that shortage, is to leverage technology to actually make care more efficient. And also by coming up with ways to, like if there's a doctor shortage, I mean, yes, using advanced practice practitioners like NPs and PAs is definitely important, but using the healthcare team, so like empowering the healthcare team with the right technological tools to improve that efficiency and also provide care at the right venue. So like what I was getting into before, like if it's not a great use of a doctor's time, like if someone's coming in for like a 30-minute visit for like a Viagra prescription, like that's something that could be handled in, maybe 2 minutes by reviewing a case, and then getting them in getting that patient into some kind of system to make sure that their cholesterol is being checked, that their blood pressure is at goal, but really figuring out ways to improve efficiencies is going to be really important moving forward, and also to reduce costs to the system.
Yeah.
I was just gonna add one more thing. Absolutely, on that. I think on what we have done at Dispatch is really around making sure that we have the right providers who go see the patients. So what we do today is we have a team of 3 that goes out and sees a patient. We have an NPPA, an advanced practice provider who goes physically to the home with an EMT. So both of them go out. But then we have an MD that oversees that team virtually. So this has been our model ever since. The good thing when you do something like that is then you get scale. So that MD is overseeing 10 teams or so and only getting called in when needed. But then the APP and the EMT are able to then see those patients. To your example, is really around if you have something as easy as a Viagra prescription, you don't need an MD to come in that, right? An APP can handle that. So there's a lot of those kind of examples that with the shortage of providers or of primary care physicians, we have to think about creative ways where we can still deliver really good care, but again, keeping the cost low is the key as well.
Good. Nico, were you going to say something? I saw you lean in. I just want to make sure.
I wanted to pull Kelly's question out. I love this question that, telemed costs a lot less than in-person visits, to actually deliver that care. That can be savings for insurance companies and patients, but it's also loss in revenue for healthcare systems. How do we think that those savings will be distributed? Will they be distributed to patients? Will they be eaten up by the health systems? Will health systems have to get smaller because they're not generating enough revenue? That used to be ED visits, for instance. Maybe Dr. Goss, do you want to try to take that one first?
I think it's a good question. I think that we definitely have seen obviously loss in revenue in terms of our volumes in the emergency department, and obviously in the COVID crisis we've seen significant financial losses for the health system. However, I see this as just essentially like another service line that you are rolling out, and there's also potential opportunities as well for continuing care beyond the walls of the hospital. So I would see it as kind of a new, potentially a new revenue stream for health systems that they could leverage. I think that actually also partnering perhaps with other startups. I mean, for example, if there's a telehealth company or a dispatch or somebody who can actually take up sort of following up with, say, a patient after they're discharged, that could provide a lot of help to the health system, which, you know, maybe that's a challenging thing for them to be following up with patients. Whereas for a company that just provides care in the home and this is what they do and they're experts at it, that may be totally appropriate. And you're using perhaps, you know, that there's an MD or DO oversight and that there's a team that's going out to visit that patient. So I think I see it as actually a financial opportunity to extend care in a way that they have not. There's also the potential of seeing specialists from other health systems. Maybe you want to see a specific, you know, specialist at the Mayo Clinic, and that may be potentially a consultation of some sort that happens virtually first, and you answer, you know, say questions that they have. So I really I think extending the walls of the way that medicine is traditionally practiced is only going to bring more utilization of medical services.
Yeah, so extending beyond those four walls. And this is our last question, unless Nico, you want to ask any further. And it just moved on me. So we talked a lot about fixing healthcare, and once we start talking about fixing healthcare, it gets really complicated. So sometimes people think about interoperability and that is so hard. I'm not going to try to fix it. That's where Nico comes in. But those problems are so large that there's an impression that nothing gets done. The question is, but you've all talked about simple communications. What can the providers do to innovate on communications on an ongoing basis?
Yeah, so I'll kind of start there. I think moving forward, like getting rid of this term telemedicine that started with the invention of the telephone, I think it's time to just put that to rest and really look at more of a model of like connected health, where everyone has access to a healthcare team that they can communicate with either by text or by phone or for video or in person or at your house. But everyone needs to have that access to stay healthy. And really the way to deliver on that is to figure out a financial model that works. The biggest barrier currently is just misaligned incentives. So there isn't necessarily that, not to be a pessimist here, but for a hospital, they're financially incentivized to do that cardiac catheterization and place stents, where they don't have that same incentivization to keep that person from ever needing that stent in the first place. So that's like a kind of big fundamental issue. And I'm not saying this because I think healthcare systems like want to put stents in people, but it's just a matter of how things are paid for. So just figuring out an equitable system where that's sustainable and works for our society, works for our employers, works for people, is really the first step there. You know, it's great to say like, oh, everyone should be able to text their doctor, but then like with a doctor shortage and like figuring out how like a doctor who's busy in clinic can just respond to text messages all day, like that doesn't work either. So like trying to find like actual systems to make it so it all works is kind of the big challenge.
Okay.
And I would just add,
Thank
as
you.
far as communication is concerned, I think that our communication systems are woefully inadequate in healthcare. I think actually, I mean, that was part of the reason I started Care was because there is a lack of communication. For example, when patients are discharged from the hospital, they get a stack of papers and they say to follow up with, you know, a person. We were just reviewing some comments from our patient experience comments this morning, and you know, we gave a patient 17 pages to go home and read, and you know, they really didn't actually appreciate that, and that was not a very effective way of communicating with the patient. And I really feel that to drive better outcomes in our health system, we really need to be thinking about how we create communication to the patient and the extended care team so that there's shared accountability. So if I'm discharging a patient of Dr. Emder's, that he's in the loop and he knows that I took care of his patient, say in the emergency department, that he knows what tests we did and what the follow-up should be. And that we also have, much like we developed these very innovative processes in the hospital for taking care of patients while they're in the hospital, which we do a great job of, we don't really do a very good job of taking care of patients after they leave the hospital. And thinking about how we check in with patients, how we're capturing sort of really important data points on how they're actually doing with their health, and a refocus back on the patient and communication with the patient, but doing that in a way that's thoughtful and integrated into the clinical workflows of the providers, such that we're not actually creating more work for them. We're making it easy for them to do the right thing, and we're facilitating communication to the patient, which ultimately we're on the hook for their outcome. So I think that there's a lot of room in terms of innovation that can happen in this area as we see patients move in and out of healthcare systems, receive care from perhaps different providers, whether it could be a telehealth visit, it could be a family medicine visit, it could be an emergency department visit, it could be with a specialist. But the problem is that we don't communicate. And I think that, that is a fundamental flaw and a problem in our healthcare system that I feel like is actually holding us back right now in terms of driving better outcomes for that patient.
Thanks for that. Clearly. Oh, go ahead, Liz. Yeah.
I was just going to say, I definitely agree with what has just been said. And I would also say that there are a lot of people working to improve this. So maybe just to, put a slightly more positive spin, as Dr. Goss mentioned, UC Health is doing a lot of work on this. There's, increasing pressure from payers and from large employer groups. And then startups like on this call, and I'm sure, a lot of people dialed in that are trying to solve a lot of these gaps. And so I think that that things are getting better, although they could certainly move a lot more quickly, but appreciate all the hard work that so many people are doing to solve such a complex problem.
Yeah, I echo that, Liz. And I think, for me, it's really, I think I echo everything everybody has said. The last thing I'd say is, unfortunately, I'd say that it took a pandemic to get all of us together and really align on incentives and get all systems of the healthcare industry, from government to big health system to startups to the patient to come together. But one thing that we can think about, really two things. One is, once we have all the incentives aligned, there's a lot of amazing innovation that can come out of this, right? So I think the hope that we can take out of this, and everybody who's participating in Boulder Startup Week, right, is that there is amazing amount of innovation that can happen in healthcare, and this pandemic has showed us, right? So there's that part that I think is going to happen, and I think the other part also, which is interesting, is that the patient has also seen a different way of delivering healthcare, and I think if the patient moves towards that direction, which is the customer at the end of the day, if the customer moves to the end of that direction and demands it, I think, and all of us are customers of the healthcare system, I think it also accelerates some of that. So I think it's super exciting in the few years we're gonna see ahead of us, and probably cause a pandemic for us to see it, but acceleration and innovation is here to stay, and super exciting about this.
Thanks, Nabil. I'm going to end on that note, and thank you all so much for joining us. Thank you, Nabil. Thank you, Dr. Goss. Thank you, Liz. Thank you, Dr. Emder, and thank you, Nico. We've just had a really inspiring conversation. I hope that you all are going back to whatever you're doing and hoping to create more innovation in healthcare as we move forward. So Thanks to our sponsors for Boulder Startup Week, honey.com, name.com, Downtown Boulder Partnership, Techstars, and the University of Colorado. This recording will live online in case anybody wants to watch it in the future. And just go to boulderstartup.com and then check out Nico and Boulder Health Tech's happy hour networking speed roulette or whatever you called it, Nico. That sounded pretty fun. Today at 4 o'clock, you can find that on boulderstartup.com. Thanks again.
Thanks, everyone. Hopefully, we'll be live next year.
Thank you.
Thank you.
Thanks.
Thanks.
Bye.
Bye.